Good morning, everyone, and welcome back to our December session of the ID and Dementia Texas. We are going to get this started shortly, but in the interim, I'm just going to go through a couple of housekeeping details here. This is our hub team. Many of you are familiar with them. For those who are just joining us for the first time, we do not have Dr. Sadowski with us today. She had a conflict, and Dr. Ezralu had a conflict as well, but she has reviewed the case that we are going to be presenting after the little educational session we have, and has submitted questions, which I'll ask on her behalf. And we're waiting on Dr. Fay, but the rest of us are here. And we are recording the session. So just be aware that we are recording. If you have any questions, put them in the chat box at any point. And everyone is muted by default. And just, if you do have questions, we will ask you to unmute. If you do have any IT issues, go ahead and put them in the chat box as well. And if you have a question at any point, you can raise your hand using the little hand icon on your toolbar that's either at the top or the bottom of your screen. Again, the chat box, you can put any comments or questions in as well at any point. And we will go ahead and get started. Kathy, I'll let you put your screen up. I'll stop sharing. And Dr. Jeter's going to lead us off.
Good morning, everyone. I'm Dr. Cameron Jeter. I'm going to serve as the facilitator for this installment of Project Echo, as I do each month. First, I want to describe what the Project Echo webinar series is all about for those of you that may be new. Project Echo is actually something started by the University of New Mexico years ago when they wanted to be able to distribute key clinical information to their rural partners in the state. And rather than moving people, bringing those rural physicians, healthcare providers, family members into the actual physical building of the University of New Mexico Medical Center, they realized that webinars could take information to those individuals and therefore lower barriers for educating healthcare providers. And this model, of course, was very unique and had a lot of ingenuity being prior to COVID. Now in post-COVID days, we're very used to webinars. But what continues to make Project Echo unique is it's not just a webinar of one-way information delivery from those of us who are on what's called the hub experts to individuals who join the webinar, but we really encourage two-way communication. Meaning, if you have a question, or even better, a personal experience to share, we encourage you to do that by putting information into the chat box that I will either bring into the conversation, or if you'd like to do that vocally, you can raise your digital hand and I'll call on you, enabling you to unmute and join the conversation. This Project Echo, like each month, is an hour and a half in duration. We will begin with a didactic or teaching session where we're going to hear from Dr. Bishop. And as you can see from her PowerPoint title slide, she's going to be talking to us about ways to modify the environment that actually helps an aging individual with IDD who's either at risk of developing dementia or already has been diagnosed with dementia. Following that presentation, we'll have a Q&A session for more questions of Dr. Bishop, and we'll transition into the monthly case. This means that Catherine Piers will present to us the details of an anonymized patient in Texas who has been diagnosed with an intellectual and developmental disability and of late has been experiencing advanced or new problems that may or may not be related to dementia. And we as a group collectively, not only hub team experts, but those of you that are attending can weigh in with questions or suggestions as we collectively work to help the patient and her surrounding caregivers and family. So once again, thanks for joining us. I'm pleased to welcome Dr. Kathy Bishop, expertise in gerontology and the sensory environment, to teach us about ways we can care for our loved ones through this way. So thank you, Kathy, for being here.
Thank you, Cameron, and the Hub team as well, and for our case presenter today, or who's on. And so I'm pleased to be doing this and honored to be doing this. It's quite a struggle because I'm trying to fit in at least a 3-hour lecture, if not a full semester course, to give you some background. I think you have to have some understanding of why it's essential that we consider as part of differential diagnosis, as part of healthcare advocacy. Always consider behavior and function and diagnostic process from the context of the physical and sensory environments. The healthy brain needs hydration, and we often find older adults with IDD in particular dehydrated for various reasons. And if there is some pain, disease process going on, or there may be a possible onset of a type of dementia, such as Alzheimer's disease, the brain damage may also be causing the person not to know to drink, to hydrate themselves. They may feel pain when they're thirsty, but not know what that sense of pain is. And so every single one of the needs of the brain goes back to the sensory information in the physical environment, being able to help give cues to the person to continue to function and to be able to provide what's healthy for the brain. Nutrition, the same thing with hunger. Rest. There may be so much confusing and frightening sensory information in the environment that the person is not able to rest and be still. And our brain, our bodies need to be able to come to rest. I have a friend, a colleague who's also a gerontologist, who often talks about it's like like you have garbage pickup in the middle of the night. It's kind of the brain is able to get rid of some of the excess, be able to rest and not have to respond to every piece of sensory information. Movement is absolutely essential. The two here, hydration and movement, are essential for the brain to continue to function. Responds very well to rhythm in particular. So thinking about how we build rhythm in the way we interact, we're part of the sensory environment. And so we can do things in rhythm instead of kind of in the just voice that I'm using right now. Stimulation without or with, that should be stimulation under or over stimulation is what that should be. I think I had an automatic AI correction there. Predictability, especially for people with autism, dementia, and other particular sensory challenges. I often refer to autism when I'm talking about sensory environment because I've learned so much from people with autism who have shared how they adapt to the environment, how they interact with the environment, and their sense of environment, their understanding of environment, and how it's challenging. So there's so much we can learn and share with each other to really build sensory and physical and sensory environments that are compatible. Always should be part of differential diagnosis and healthcare advocacy. It's the only way human beings connect to the world. I can't say that enough. Our vestibular system, which is located in the inner ear, is the sense that connects us to the world. It's like the doorway to the outside world of self. And it is often, especially in dementia or later years, is the sense that is most impaired, meaning that the connection to the world is a challenge. And so that's why we always talk about in dementia capable care, you must really support people staying connected to the world. They may not be able to function and perform skills as they did in the past, but if they're staying connected to the world around and to others around, that's the most important way that we can help support people in the process of decline that happens from brain damage. Then the vestibular, and there's like mini seconds works closely with the proprioceptor sensory system, which is location in space and time, where our body parts are located. These are the two primary and considered the first senses in the near senses that locate us in space and time. Everything we do requires us to connect to the world, requires us to take in the information, know where we are located in space and time. We couldn't be together. You would not be able to sit and attend and be part of this webinar if your vestibular system, proprioceptor systems weren't making it possible for you to locate yourself in space, be able to use the computer. Then, in coordination with the brain, the other 5 primary senses of hearing, visual, tactile, smell, and taste. All of those all 7 send information to the brain where sensory processing takes place to be able to make sense or be able to understand and make meaning out of the sensory information. Approximately 70% of what we process, the brain decides doesn't have to pay attention to it. It's habit, routine, nothing to pay attention to. And at least 70% of what we do every day is by rote without thinking. You don't think the steps of exactly how you turn on the computer and how you get to each program and each what you need to the browser, for example. That has become rote if you're using the computer every day, on and on and on. Though in Alzheimer's disease in particular, by the way the brain damage occurs, that information, your most recent habits, are those that are lost first. And those are the ones we need to connect people the most to keep them functioning in space and time. Adults with IDD have difficulties with sensory reception, impairments, and processing over a lifetime, as do many older adults without the pre-existing intellectual and developmental disabilities. Here are the 7 primary senses: the vestibular for balance and connection. If we're not balanced, if we're dizzy, nauseous, out of balance, we can't pay attention and connect to the world around. Allows us to stand and move through space without falling over. And then the proprioceptor system for position, the sensory feedback that informs us where the parts of the body are and how they're moving. Both integrate input from the following 5 senses. And the muscles, joints, and bones of the body are the primary sensors for proprioceptor. Anytime people are sedentary, are not moving through space, for any lengths of time, there can be muscle loss, and that muscle loss means there's less receptors to restore balance. That's why you'll see long-term COVID, for example. Many of the symptoms of long-term COVID are dizziness and lack of balance. That's because the proprioceptor and the vestibular system, probably some damage, and certainly some damage to the receptors, meaning there's less sensory information coming in. Tactile, visual, auditory, smell, and taste all work closely together for a person to be able to function. The near senses, as I said, are the vestibular and proprioceptor. Those mean they're the closest to the brain, and also the ones that have to function for the other senses to function. Tactile comes next, then vision, and smell and taste. This is the sensory input. Then this is sent to the brain in a healthy functioning person, processed there, and the information interpreted to be decision made in a very complex process with many, many steps for the brain to interpret what to pay attention to and what to ignore, because it's just part of habit. It's nothing dangerous. That's partly the fight and flight response. That's why you'll find many people with dementia, Alzheimer's disease in particular, moving, looking like they're lost through space, looking anxious and being frightened of sensory information that we think they should not be frightened, such as shadow in a corner. Instead of looking at it as the problem of the person, we need to look about how we remove that shadow, how we make the sensory and physical environment suitable for the person. And then a response, which we hope will be response. Here's that very first point of connection. know that 60% of people diagnosed with Alzheimer's disease have vestibular system dysfunction. That's why it's the most researched sense in terms of Alzheimer's disease and how we can support people. Results in confusion in time and space, inability to wayfind and interpret the sensory information. We all have a cognitive map that for most of us is a visual map, or many of us is a visual map that helps us move through space. It's kind of like a visual map with all the landmarks you have around that you might follow. For example, it can be like a GPS with much more visual landmarks. With the disease of Alzheimer's disease and other types of dementia, that cognitive map can be destroyed, or the connection to get to that. So your visual memory is gone, making it hard to use objects and to function in space. And people react by looking confused, interact and move less in space, and increase cognitive decline. It's amazing to me people continue to function throughout this disease. It's amazing to me that we don't have more sensory processing problems. Awareness of one's body, lost in space and time. I can't emphasize this enough, how frightening it is and how difficult to function. Problem of location in space. An example can not perform functions of daily living if we cannot locate in space. Could you solve a complex math and word problem while free falling on a roller coaster? Here are some examples of creating pathways. They're not great examples because I can find horrible, bad examples. But so I just have to use what's available or what I can take pictures of myself. You can see this hallway helps because at least there's contrasting color down the edges. However, you see there is absolutely no cueing and nothing to tell you what each of these doors are, and why we're even moving to space and where we're going to at the end. This sign up here may be creating, I assume it's an exit sign, but it's not very clear, especially for a person with dementia or intellectual disabilities that may never have understood what an exit sign means. And you can see there's significant glare throughout, causing shadowing that could look like a reaction that we would label paranoia or hallucinations when it's the physical environment giving cues. We see there's a pathway here, but see how confusing this pathway is? You see how the light, the amount of glare and light, and all the images on the ground, this could be extremely frightening for a person. We would not want to design an environment for people with dementia with this amount of light, or at least the ability to stop all of this glare and all of this confusing sense of space. Here was an example of creating a pathway to get to the couch, also using contrasting colors on the walls as well to create a safe pathway for people to walk through. And that's what we want to be doing. We don't have to go out and buy expensive furniture, expensive floors. We can use what we have, but we use the contrast of making sure there's good lighting, lack of glare as much as possible, and that we're using furniture to help, as well as contrasting colors. For example, if you wanted to keep this a carpet here, it could be a strong contrasting color to help lead you to the space for the furniture. The opposite is true. If you don't want people using certain spaces, you try to create pathways that take them to the safe spaces and the objects that they want to use. Being lost in space and time often results in tactile defensiveness, with people walking through space, and we always call these as inappropriate behaviors. They're a response to a physical and sensory environment that is now frightening and meaningless. It may have been throughout a lifetime, and we've written up extensive behavior plans. We see people who don't have attention span, and we think it's just because they're being irritating to us, when in reality, this being lost in space and time can make it impossible for something to function. This is just maximized as the brain damage continues. And so we're always, our first challenge in necessity of what we must do is to locate people in space so they can feel safe in space and time. The vision is likely the sense most relied upon, especially for those of us like myself. I'm an extremely visual learner, and I need to see actual activities, or I need to write down directions on a piece of paper, and I visually can remember those steps on a piece of paper, but I can't remember in the same way auditory information. It is thought that for people with Alzheimer's disease in particular, but probably other types of brain damage that occurs as well, that the dependence is on vision more and more, and understanding auditory cues becomes increasingly difficult. We have a loss of elasticity in the eye, which means that acuity is impacted. So busy and cluttered figure backgrounds make it difficult for people to use objects or to move through space. And again, this appears to be the sense from research that is most affected by dementia. This is how the world may appear for people with different types of visual impairment, which means confusion or less sensory information is coming into the eye. Diabetic retinopathy, cataracts, retinitis, pigmentosis, glaucoma, and macular degeneration. Again, you can see how difficult it can be, especially for people with dementia having increasing brain damage, who to be able to interpret and use the physical environment. Again, I'm amazed that people aren't frightened and confused all of the time. Here are different types of lighting. We need to be really, really careful the kinds of lighting we use. For example, a fan with a light in it. We may need the fan, but we may want to be careful, because what would be happening is creating moving shadows. And there's therefore moving sensory information in the environment that can cause great fear. Chandeliers typically are more for ambient lighting, rather than actually really lighting a room fully. Track lighting is one of the best options, especially in hallways, but in rooms where we can't do task lighting or pathway lighting all the way, they'd get in the way of the pathways. We can have the track lighting on walls with movement that we can use to be in different places and reduce glare. We also look at the surfaces the lights are hitting and make sure they're not shiny surfaces. We need to make sure to reduce visual clutter through organization. Also know each person's previous habit and routines, so you can build that organization into areas that the person typically would use. If there are objects you don't want people to use, unless they're being supervised, maybe they like to cook, and they can cook using a knife, for example, still with supervision, but certainly don't want them to have access to the knife. We want to remove all of those visually out of the physical environment, so that people aren't going to dangerous objects. Contrasting colors and textures can be used to help locate people in space, find the objects you want them to use, and you should always have chairs with arms. Contrasting color so people can find the chairs easily, made for the shape and size of the person for ease of use. And contrasting color doesn't mean you have to buy new furniture if they have arms and they suit the person, but you can use it through textures and materials on the backs and on the sides of the chairs. A bedroom with good contrasting color, there's still, if you see on the floor, there's a problem here. That would be a problem of figure ground. You really would want one color, one consistent color, except if you want to mark a pathway, but that would be with one solid color, not with a lot of visual information, sensory information in the carpet or the walls as well. You want to reduce that as much as possible. Here's how chair railings or railings can help give contrasting color. I've had individuals that I've consulted with that we have actually put textured material on chair or handrails, so the person can feel their way to a bathroom or to an area of the house that they're using, or an area of a program to help guide them. And again, you see on this chart the contrasting colors. Furniture for ease of use, contrasting color to the background, and walkway. Arms always on chairs. I can't emphasize that enough. That helps locate people in space. It helps give them a sense of territory, which people need the sense of territory. Material objects are important for people with territory. We do not want to remove material objects that are important to the person from the environment, but we want to make sure they have a good background, good capacity of contrasting color so the person can, as much as possible, continue to use. Here is an environment I'd never recommend these kinds of couches, but at least this has a good contrasting color and kind of a pathway to there, as well as we can see the function of this area of the room, and we can mark areas of the room for their use by the furniture and by the colors we use for contrast. The ear is the receptor of multiple. The vestibular system is the inner ear, but also the ear for sound, the noise and sound in the environment. We want to reduce background or meaningless noise as much as possible. And we need to always be thinking of all of the senses, not just one. Insulation on walls, and that insulation can actually be soft materials, hanging materials on the wall instead of having framed objects with glass. We'd want to have materials that are framed that do not have glass. Those are absorbers and act as insulation. If there's noise between room to room, you can put a shelf with all kinds of books or objects on that can help reduce some of the sound from the adjoining room. Covering windows with heavy curtains also reduces noise that may be coming in from outside. Placing larger pieces of furniture like a sofa against the wall can also be useful in blocking out that background noise. Also, think of the sources. You don't want radios, TVs, people talking all at the same time. You want to do as much as focusing on having the meaningful sound that helps people be able to function. Smell and taste are very closely related. The sensory experiences of sour, sweet, salty, and bitter make up taste. And taste interacts very closely with smell. And it can be flavor is detected using taste buds, but we can also, some of the flavor comes from the smell as well. Do not remove baking smells and other smells, even if the person is on pureed food. Try to make the pureed food look attractive. Also, make sure that baking is being done. That helps stimulate the memory of hunger and the memory of eating to resolve that hunger as well. Impairments increase with age. Let's see, change the environment, not the person. That's the most important. Consistency of objects in the environment. Here are three. I think each one of these are kind of horrible, but at least they give examples how there are different types. If any of you have traveled the New York State Thruway, for example, or other throughways, you will find interstates, you will find that people that the way people get water out of faucets can differ. I find myself on the New York State Thruway doing my hands underneath, trying to get the water to come, expecting that that's the type. And then I'll look to someone next to me and I'll see they're using the faucet that was there that I didn't see. In homes and programs and in family homes, encourage the same faucets throughout so people can develop a habit and the brain doesn't have to focus on. That's true of all objects. Consistency of the type and how you use the objects in the environment can help people still within the dementia develop visual memories as much as possible, and restore some things to the cognitive map, to the memory to be able to use. Here's an example. This is too much beige on beige. Here's white. There really should be contrasting color here, contrasting color around the sink. All the objects we want people to use should contrast to the background to be able to help them be able to use that background. Invariably, I find in most homes and in most programs, bathrooms are white on white. giving no pathways and no sensory information to help people continue to use those bathrooms and objects. Blame the environment, not the person. Evaluate the environment, especially within dementia-capable care. Create pathways using contrasting colors, railings on walls with texture and contrasting colors, furniture for ease of use, good lighting without glare. Paint, materials, and textures are the simple and less expensive ways to modify environments for ease of use. Take photos and videos to remove yourself from the environment. I think that's something we might want to think about doing in terms of case studies. For example, we might want to have some photos sent from the physical environment, or at least the parts of the environment that are causing the most amount of challenge, the most amount of difficulty of the person being to interact with others, so that we can also see to recommend some ways to change as well. Always, always blame the environment. Always, always assess medical needs, assess people's inappropriate and dangerous behaviors. Dementia, part of that assessment should be, are there things in the environment that are interfering with functioning as the person has functioned across the lifespan? So thank you. I'm sorry, I know but there was a lot of information that I threw at you. I hope that it was enough to be helpful for you. Let me stop sharing and turning it back over.
Thank you, Dr. Bishop. One question I thought that I'd like to ask for everyone is, what are clues from the individual with IDD that tell others they need to make these environmental changes on their behalf? Is there a point that they should be made, or should they always be there for universal design?
Always be there. We should know across the lifespan. I am sure, because we know so little about sensory processing, how the brain uses that sensory information, and we have difficulty detecting sensory impairments because people can't communicate with those who often can't, with those they're evaluating. Oftentimes, the clues are behavior and function, refusal to take transportation, for example, because it has bad smells. There's not good pathways, safe pathways to be able to get onto vans or buses. Sounds that are frightening and meaningless. Always, always from infancy on should always be considered from the context of the physical and sensory environments. Clues are difficulty functioning, moving through space, difficulty interacting with others, and changing function. And so instead of, especially for people with Down syndrome who have a higher rate of visual and auditory impairments, and I suspect a very high rate of vestibular, which, remember, without that vestibular functioning, people are not connecting to the physical and sensory environment. We're finding more and more people with Down syndrome are being diagnosed also with autism. We know for people with autism, vestibular and proprioceptor are, for most people with autism, the most challenging, why they have so much trouble interacting with the physical and sensory environment. So there's never any start point. There never should have to be. There should always be taking the person's function and behavior within the context and sensory environment, and understanding that disease process of a type of dementia will cause significant loss, will show up as symptoms, but always start with the physical and sensory environment first, not last.
Dr. Keller.
Thank you very much. Dr. Kathy Bishop, wonderful presentation. And I think it's hugely important to emphasize everything you just said about the environment is so relevant for consideration of any change of function, behavioral difficulties. And yes, as you know, I'm a neurologist. And I think what's very fascinating is that I'll just give you, and this will, nothing about what I'm about to going to say is going to shock you or anybody else, is that as people come into my office, my clinic, who sees individuals with dementia, whether it's with IDD and dementia or normotypical population with dementia, is that when they walk into the physician's office, I would bet, and not that I'm taking a poll in this one, is that most doctors, I know you know this, are not thinking about the environment. They're not thinking about the psychosocial dynamics of the challenges. The story comes into my office of the problems, and then the medical hat, we put on our medical hat, and we're thinking that it's a medical problem. It's a medical problem, and therefore it's a medical solution. And this is kind of where it's such a quagmire. I'm actually just coincidentally, I'm giving a echo at 5 o'clock today to the Down syndrome medical interest group. And you know what it's on? It's on this topic. It's on this topic. And the topic it is, and the people that come on the DISMIC, the Down syndrome medical interest group, are physicians. These are often Down syndrome clinic physicians who definitely know what they should know, but it's still the medical model of what it is. So in my presentation, as I am going through underlying medical factors, at least from a medical standpoint, is what should the doctor know in regards to the medical issues, pain, visual change. I mean, it's got a lot of things you're talking about, and what should they know? Too much medication, et cetera, et cetera, is what should they do to evaluate that person? And then part of it in my presentation to them is exactly what you're talking about. And it's a matter of for they to recognize that it may not be a pure medical problem that's causing their changes, which it could be certainly, but it's something that might be environmental, social, or personal. And therefore, what's the role of the doctor when that might be relevant? What should they say? What should they do? What they should say, I'm answering my own question. What they should do, they should not quickly put up a prescription. I'm gonna give them more of a drug to tranquilize them and curb their behavior. That should not be their knee-jerk reaction. It should be looking at the environment and those social issues and reflected back to the people supporting caring for them what you're talking about. And I think the problem I see, I'm going on and on and on, is that we doctors are often looking to be the solution. Dr. Keller, my patient is agitated. Dr. Keller, they're not sleeping well. Dr. Keller, and they're looking for me basically to give them a treatment, a medicine to help their problem.
Lots of responses. One of the first is, I have only recently come to truly understand the entry point and the importance of vestibular. So in your talk tonight, you really need to emphasize that the only way their patients can connect to you is through the vestibular system and working closely with the proprioceptor system to be located in space. So I look in your office. Well, I often think about myself. I need to have oral dental care. I don't want to do it in the US. And there's some other procedures now. There are countries like Thailand and some South American countries that are really providing for those that have the resources to go and to receive care in a hotel room or something like a hotel room in a place. I look at your office, which is designed to be sterile. So we think of sterile as being high glare and high white. It's not. We need to get colors in and contrast in space. I suspect you have patients that can't get up on the table to be able to. Is there a way easier?
Here's my.
Yes. I mean, I find myself as I'm older and I get a little bit shorter, not being able to locate myself and be able to get up on there and feel safe up on there. We don't have to have them designed that way. And so I think getting some training for people who are doing good medical care outside the US of how to design your offices. That's the first, really looking to the waiting room and the offices. Why aren't there all rocking chairs in the waiting room? Why do you have these uncomfortable chairs that are right on top of each other? Some simple things you can do. However, I don't think you need a multidisciplinary team. I think you shouldn't have to be worried about their physical and sensory environment. There need to be people trained on the team that can take photos, that take pictures.
Yeah.
Every organization should have a gerontologist. I wish healthcare providers would have a gerontologist if you're working with older people, especially older people with IDD. And so I think and they could be helping. There are also a few people, designers around the country that could come in and design your offices and that part of your responsibility of people's physical environments. That's a short version to something we could spend a whole week on.
I could as well. Thank you.
Yeah, and we should talk about it for the presentation we're doing together in the spring.
Good point. Good point. Thank you.
Yeah.
Thank you, Kathy, for bringing forward something so important but often overlooked or not even acknowledged in everyday care for adults with IDD. Now we're going to transition to our next phase of the Project Echo, which is our monthly case. As I mentioned earlier, this is an anonymized patient who lives in this great state of Texas, for which our Project Echo is directed and focused. And Catherine Piers is going to be bringing information about our patient this month and guiding our conversation. So thank you, Catherine.
Thank you very much. So I just put up page 4 of the EDSD, and I've got page 5 up there as well, just as a really great visual representation of the changes in this individual just over the past year. And I'm going to give you the background here, but as you can see, as we scroll through those pages, whoops, go back up. That was page 5, sorry. This individual has experienced considerable change just in the past 12 months. So let me give you the background on it. This is a 45-year-old female with Down syndrome who's classified as moderate ID and just recently moved into a group home with 24-hour care. Historically, she's reported to have been generally very healthy and very high functioning. Always lived with the family previously and lived independently as a young woman, was able to manage all her daily living tasks on her own. In February 2023, when she would have been 43 years old, she was diagnosed with Alzheimer's. And this came about following a sudden loss of motor skills. That resolved after a few days, and she did return to her near baseline functioning, but continued to demonstrate what's termed a mild gradual decline over time after that. In May of this year, she experienced a second similar episode, which was also accompanied by delirium. This resulted in a 3-day hospitalization, and the family reports that numerous tests were run at that time, all of which came back, quote, clean. And again, she partially recovered. And at that time, she was started on medication for anxiety and delirium. Most recently, she's had a third and even more severe episode, that episode meaning that motor changes and cognitive decline, with a 10-day loss of mobility, had trouble with her eating and disrupted sleep. And that episode has lasted for several weeks. Although she has regained some mobility and sleep and eating have improved, she's now requiring prompts for all activities of daily living, and hence is now living in the group home, has moved to the group home. So you see the EDSD here. If you were to look at the first page of it, which I'm not showing because of privacy, not wanting to divulge names and locations and so forth, but you would see that the significant life events box was checked off, the change in her living environment, new staff and housemates and so forth from her move to the group home, which was just within the last several months, last 2-3 months. And as you can see from pages 4 and 5, she's had significant changes in almost all domains: activities of daily living, language, sleep-wake patterns, ambulation, memory, and behavior and affect. So huge changes for her the past year. Relevant diagnoses are hypothyroidism and hyperlipidemia, the diagnosis of Alzheimer's, allergic rhinitis, and recently a blood clot in her leg, which was diagnosed through sonography and is being treated with Eliquis. She does have a vision impairment. She's worn glasses since she was 2 years old. She did have, quote, extensive blood work in May of 2025, which was reported as being within normal limits. She was offered a CAT scan, MRI, and EEG in 2023 when she had that first episode, And several attempts were made to get those scheduled, but the individual did refuse, and so eventually that was given up. She's on Eliquis for the blood clot that I mentioned, levothyroxine for hypothyroidism, Claritin for allergies. Namenda was prescribed for her, quote, forgetfulness, Singulair for allergies, and Zyprexa for her insomnia. The family's goals of care are they want to support her to remain as mobile and independent as possible while ensuring that she can live a happy and fulfilling life and preserve her abilities to the greatest extent possible. And the primary question for the hub team is, why is she experiencing such an accelerated progression of Alzheimer's symptoms instead of the more typical gradual decline? So I think two things here. One question for the hub team is, do we think Alzheimer's is at play here, or could there be something else that is accounting for these sudden changes and rather profound decline? And also, regardless of that, are there suggestions and strategies for how we can help her remain as independent as possible and functioning within her environment and in her daily life, aside from the diagnosis, given the changes?
And
So,
Catherine, she has Down syndrome, correct?
correct. And she's 45, diagnosed at the age of 43 on the basis of symptoms, the change in mobility. I'm going back here. Sudden loss of motor skills, which resolved after several days, returned to near baseline functioning, but has continued to demonstrate a decline over time. So she's had this sort of stepwise downward progression. She's had this mobility issue, sudden onset of mobility issues. They resolve, and then she's kind of stable for a while, and then she drops back down. Then there's another problem with these mobility issues and sudden change, stable and down. Do we wish to ask the person who's brought the case to us for some detail on that?
Yes.
She's nodding her head, so I'm guessing she's saying, yeah, she would like to contribute. So you can unmute yourself. I was going to say I'll have to unmute you, but I don't have to. You can do it yourself.
I just wanted to clarify that in between, it has been a strange, these episodes, as you've referred to. In between those episodes, baseline still had been changed, right? So forgetfulness, perseveration, repeated questions and stuff like that, that did continue. It just wasn't as severe with the mobility, fearfulness, extreme perseveration, and, kind of rapid cycling of asking this question over and over again. Those episodes were the kind of the fewer and farther between, but in between those, she was, very clearly showing decline in cognition and memory. She remembered people very well and some events from her history, but was short-term memory was certainly affected. And when, as Kathy was talking about her, she was very much lost in space and, stepping over thresholds, and that type of mobility was still affected in between those episodes. But the episodes were very significant and scary for her and scary for the family, and mobility and all the other things were affected during those episodes.
Kathy, please lead us off.
Why don't you let Seth
Okay.
as the medical and
Continuation.
medication and that, and then I'll follow.
Yeah,
Thank
just
you.
some clarification. Thank you very much. Clarification. She lost mobility or strength. Can you explain what that means? Because that can mean a whole bunch of different things.
Yeah, and to be honest, some of that was some stuff that I didn't see that was happening more so at home. It seemed what I witnessed, and I don't know if this is what the family is referring to that was happening at home, but what I witnessed was more a fearfulness of movement. And so she wouldn't want to stand up. She wouldn't want to move.
But that's an
the patient.
assumption. There's almost an assumption that's what you think.
Sure.
You think
Yes.
she's
No,
afraid. I mean, I
correct.
understand it. Like, we don't know for sure. That's like
Right.
a conjecture on all of our part. We do a lot of
Correct.
conjecture.
And I
But
do
she
know that
wasn't like paralyzed, because that's what I think.
I think
Literally,
the
was she
most
like
recent,
paralyzed?
Well, I think the most recent one, and I wish the family I think was planning to be here and they're not, so I wish they could speak on that. The most recent one, I think there was some loss of mobility. She didn't seem to be able to get out of bed. And so I don't know what that looked like. That was the report to me, was that she did seem to officially lose some ability to be mobile. And I don't know exactly. I know that that was extensive. It
That's
lasted for
okay. And she
several
was
days.
hospitalized, and apparently the tests were quote unquote clean, right? Clean. Do you know what
Correct.
that, do you know what test that means? What were the tests? Because that's vital to everything. Because you then the case was also mentioned, offered MRI, EEG, and CAT scan and refused or couldn't
And
do it.
refused those.
So
Yeah.
what tests were done that were clean? Because right now, without knowing about it, my mind's racing about all the possibilities. Because the one thing that's about this case, this is very atypical for Alzheimer's, even in early onset. Because it does usually, I mean, I've done this for a lot of years, and I've seen lots of people that are in their 40s that do have Alzheimer's disease, that this is even atypical for that. It's not typical where they have this bad, all of a sudden, boom, they have this horrible thing and then recover from it. It's this progressive, progressive, progressive. And so in the person recovering, that's unusual, which is good to get better. The other question I have is this individual having jerk-like activity at all? Like all of a sudden, do their arms or legs jerk? Are you aware of that at all?
I think I witnessed some of that. More so, I noticed shaking.
Because that's huge. Because what this is really interesting. Because what it is that what's highly prevalent in early onset Alzheimer's and Down syndrome, especially when it's this young and progressive, is myoclonic epilepsy. And when people have myoclonic epilepsy, they fall, they jerk, they move, they progress, they're fearful. So I'm wondering, and this is just again conjecture on my part, is whether this individual has been having myoclonic epilepsy untreated, which might be contributing to the problem on top of the problem of Alzheimer's, if that's the case.
Interesting. And to be honest, I don't know what all the tests were. I know there were a lot of labs done.
Is it the test really what it is for myoclonic? What that means is a quick jerk. So
Mhm.
and that's common in Alzheimer's and Down syndrome. And that's it. You just see the person do that. That's it. I mean, EEGs would confirm it, but it's your eyeballs. Your eyeballs see the person jerking. That's myoclonus, and that's what it's called. And if that's what's happening, then I'm not going to say case closed, but I'm going to say that leads to a very important piece of the puzzle that might help go in the direction of a therapy or an interaction or an intervention, just one of them. I'll
Can
let
I
Kathy
ask a
finish.
question,
Yeah.
Seth?
Yeah.
The for me, the significance of a blood clot in the leg, I would also wonder, was stroke thoroughly ruled out?
Well, they
In
had to
the
have a
very
scan of the
beginning?
brain. So Kathy Bishop, so my thought exactly in the hospitalization, all things being clean, was it excluded that the patient had a stroke, like you're saying, or could they have had what's called encephalitis? So if you actually have an infection of the brain, you become delirious, you're out of sorts, you're not right, and that's by EEG and a lumbar puncture. So the tests that are done to help look for the possible differential diagnosis of what could be going on and not jump to a conclusion that it is Alzheimer's. Is it possibly Alzheimer's? Certainly could be, and maybe that's the case. But there's some questions, which is good to hear this case that kind of makes us one of these things. But a scan of the brain, an MRI specifically, because a CAT scan, even if a CAT scan was done at the very beginning in the first initiation, could be normal. So, and I'm a stroke doctor, you know. So if a stroke is occurring, you would have to really do an MRI. But if it's a stroke, it's half of the body. So if it's not just your legs don't move, that's not a stroke. A stroke affects one half of the body. So that would be what the physical exam would look like. We mentioned weakness and all that. Well, what does that mean? That's kind of why asking these questions to parse it all out, it matters.
Yeah, yeah. And go ahead and let Catherine go next, but I still have a number of questions I wanted to ask Cameron.
So, yes, I think it's also a very atypical presentation. And first question is, Dr. Keller was describing the myoclonic jerks, where there's just this quick, sudden sort of jerk. You had also talked about shaking. Are you seeing the shaking more than jerking that you've observed?
Yes,
So
that I've
not
observed personally. Yes.
so not really the myoclonic jerks then that would or seizure
Well,
activity,
video would
more
help. I
shaking.
think if we
Yeah.
actually saw the video, one person's tremors, another person's myoclonus.
Yeah.
So to me, not that I don't trust your observation on it.
Sure.
So I always want to say, well, what do you mean? To me, it's almost hearsay.
So
What
good
it's hearsay.
good recommendation then would be for them to get a video
Yeah.
of it. So my next thought was giving, and next question, and then I'm going to give you a thought. Talking about the mobility, and you said something that made me wonder if it was mobility or something else. You said didn't want to get out of bed. Now, which one of these episodes when she was hospitalized? I think the last one you talked about, she was diagnosed with delirium. Now, delirium can make people not want to get out of bed. They just want to sleep all the time. They don't want to eat. They don't want to do anything. And it just made me wonder whether it was a mobility issue or if it was related to the delirium. When she did get out of bed, or was she able to walk, or was it just that she didn't want to get up and do anything?
These are good questions. I don't know the answer to those. It sounded like it was a very severe experience, upsetting experience for the family. So to me, how it was reported to me was that she was unable.
Right. If you're having tremors and you're jerking, that would be bad, because myoclonus, again, I have no idea if it's myoclonus, it'll actually make you fall down to the ground. You lose tone of your body. And so many people that are going through this one can't walk and are afraid to walk because of the fear, because they do fall and get hurt. And it's scary. It's as scary as all can be. It's startling.
So just that was just a thought, was whether that mobility was less mobility and more related to delirium and that hypoactivity that can come with delirium that can make someone not want to get out of bed. But here's my other thoughts. My first thought when I was reading this was, given her hyperlipidemia, was this maybe a vascular dementia, which can progress in sort of a stepwise downward progression. And maybe these changes, the stable and then dropping were related to transient ischemic attacks. Of course, she's not wanted to have an MRI. So hard to diagnose those things without that. But then I had another thought. And so I'd be interested in Dr. Keller weighing in on this thought too. She has hypothyroid. There's a condition known as Hashimoto's encephalitis. And some of her symptoms kind of are consistent with that. And in fact, there is a form where you can have these relapsing situations and then they remit. So the symptoms kind of, come and go. And she's got some of those symptoms. So that had me thinking that maybe it's worth some more blood tests to see
It's
about
an antibody blood
that.
test. Huh?
Right.
It is.
It's an autoimmune issue.
Yeah, you could check.
And I'm sure she gets the regular, TSH blood test and so forth, but this is a different blood test. And in fact, correct me if I'm wrong, Dr. Keller, but those tests could be normal, but she could still have Hashimoto's encephalopathy,
Sure.
which would require different blood tests and potentially a lumbar puncture
It's worth checking.
to check.
Yeah,
But-
and as an aside, and again, I'll let Kathy Bishop chat here, but you got me going here. This is my neurology brain. You're sucking the energy out of my neurology brain. So let's talk about stroke for a second. People with Down syndrome are indeed at risk of strokes, and in particular, there's a rather not a rare condition, but a condition that is commonly seen in this rare condition called moya moya. And moya moya is a vascular abnormality of the main blood vessels of the brain. And moya moya in Japanese means wisps of smoke. And so on imaging, you see these blood vessels that are faint looking like that. And that's the nature of the blood vessel. They are small and frail, and they don't give enough blood circulation to the brain. It's called moya moya, M-O-Y-A. M-O-Y-A, and that causes strokes in people with Down syndrome and other kind of conditions. And it goes back to, is it a stroke? So if it's strokes, it's not that hard to tell. It's not that difficult to know. It's really not that complicated. It's called imaging of the brain. So you get an imaging of the brain, and you'll see it. And if you want to know about moya moya, you check the circulation of the brain, either an MRA or a CTA. And any test you want to do, you can do what's called conscious sedation. And conscious sedation, you have them go to an anesthesiologist at the center where they do the imaging. They give them some kind of minor, maybe a prep, or they give them some medication to kind of get them sleepy. I mean, that's what I do. So when I want to get my patient with an IDD studied, either inpatient or outpatient, they do what's called it's sedation. They give them IV sedation, like I'm sure all of you had colonoscopies and all that kind of stuff. Well, that's what it is. You give them an IV if they can get the IV, and if you can't get the IV, and you give them an oral type of liquid or other kind of medication to make them sleepy, so you can get that test done. That's important to do.
That was going to be my next question, is how do you do it for someone who's refusing and who's afraid? And
you got to do it.
Yeah.
Otherwise, you got to do it.
I just had one last quick question, and then I'll yield my time to Dr. Bishop. Given all the changes she's had over the last 2 or 3 years, it wouldn't surprise me if there might also be an element of depression and anxiety. She's had to move to a new location. I'm sure she's aware on some level she's lost these skills. If any one of us had the changes she's experienced over the last couple of years, I think we would have a certain level of depression and anxiety. So A, is she receiving anything for that currently? And of course, severe depression can look a lot like Alzheimer's and can cause a lot of these changes in functioning that you're seeing. So I'm not saying that's the whole thing, but that could be a piece of the puzzle too, in terms of her continuing appearing like she's going downhill. It does make me wonder if depression, anxiety.
Well, she's being treated. So here, Catherine.
Is she being treated for it though?
She's on Zyprexa. So let me ask you.
Oh, that's right. She's on
So let me ask you a question. Why is she on Zyprexa? Because it was mentioned for anxiety.
It was mentioned for insomnia.
Insomnia. Well, that's not the drug for insomnia. That's an antipsychotic drug for people with, psychotic behaviors. So what the question would be, going back to Catherine Pierce and your question, is what's the role of Zyprexa? What is it expected to do? It's called targeted care, targeted medicine. So you got to know exactly what the medication is. And I can't believe that Zyprexa just was picked out of the blue for quote unquote insomnia. I doubt it. I think it was, I hate to say it like that, I think it was because of behaviors. Zyprexa is given for people with bad, difficult behaviors, and that's what psychiatrists and medical professionals do. And so-called the insomnia is probably this person that's agitated and sundowning.
She's sedated.
Yeah, and you're basically using Zyprexa, so it's insomnia. But let's hear more about the insomnia. What's that behavior that you're calling insomnia, right? Let's just dig in that a little bit.
Yeah, I mean, I would agree with that. I mean, I think just being in this world in where I live, I think that is a go-to for physicians when they aren't quite sure what else to do, especially with those with
the side effect. Then you have to look at I'm not shocked. I've been
Right,
around the block to know.
That's not
We've been around the
uncommon,
block to know. We've been here before.
And I do think that there was some element of, because she was not sleeping, some element of what looked like psychosis, certainly. And so I think that's probably potentially the reasoning behind that. During those episodes, she won't sleep, and it's delirium, and she can't be calmed, and she's unreasonable and all of those things, right? So I think that was the reasoning behind that during that episode.
I'm not saying it's right, but I'm not surprised.
No, yes, I understand.
Yeah, thank you.
She also had we were hoping that, because during that episode back in May, I just highlighted to the family potentially look at, like a UTI causing some of this upset. So she did have, but it was very mild. And they said that if for anyone else, they wouldn't have treated it, but because she was having some of these strange symptoms, they treated it.
Yeah.
But that, just for whatever that's worth, that was coincidentally or not coincidentally occurring at the same time.
As a person who's had a lifetime of UTIs and granulars and stones, I don't know what mild UTI would be.
Right. I don't know.
It's either there or not. So it was appropriate approach to it should be treated, and looking at how it's being treated, and also making sure if it's okay for her diet, she should be having yogurt. as she's been treated after, because you need to restore the good bacteria as well. And so that's real important follow-up. Let me first of all say I've been in your shoes with presenting cases. None of our questions, we all are very intense. None of them are meant to imply no one has neglected or we're trying to get to what can we do today. So I just want, having
Sure.
been in your
No,
shoes, I know
exactly
how
right.
it feels. You can
Right.
be an expert, but in your situation, it always feels like, oh, did I miss it or what's wrong? As a gerontologist, let me also say I will guarantee it's many multiple underlying causes. And the other hub team has brought up a few of them. I have put here side effects of medications and interactions of medications in capital letters. Really needs to be ruled out. The other thing in capital letters, I'd like to know a full detail of how a diagnosis of Alzheimer's disease was made, what kinds of testing, what kind of differential diagnosis. Was it made by someone who knew how to do this and worked with people with Down syndrome? Or it was someone, and I have personally, horribly, in the past year and a half, had two neurologists who refused to work with one of the individuals I was working with, and the team desperately asking for some more information and help and refuse. And I always say this, cover your ears, Seth, but this is the reality, especially of rural areas in the country. So I'd like to go back to the diagnosis itself. Not that you're going to remove necessarily the diagnosis, but I really think we need information on what was done. And if it was done in one or two visits, I'll guarantee you they were reading the higher risk factor, that they probably got a 3-hour lecture in med school, and not really looking at doing the differential diagnosis, I suspect. So I think what's important now is to really do a very outlined and thorough differential diagnosis now. And so that's what I think you want to gather together of what needs to be ruled out. And there are a number of things that already have been ruled out. I would also, I don't recall anyone mentioning pain. Many of the things that we're talking about cause pain for. Is there been any attempt of pain, and hopefully not just a PRN? So that's means the acronym we often say stands for patient receives nothing. She's obviously reporting a lot of things and letting us know that she's in discomfort, pain, fear. And maybe it could be a Tylenol. I hesitate to say aspirin only because I do know that there are people with Down syndrome that do react, but they also sometimes with Tylenol, being very careful how the pain management is done. But I think it should be done on a daily basis and not as a PRN. And so that should be looked at, being careful not to add too much into this whole cadre of medications. We're not even sure why she's on at this point. The other thing I would really like to know, this poor lady's total habit and routine. Remember, I said 70% of everything the brain does in the processing is dependent on habit and routine. I mean, she hasn't had a habit and routine for quite some time. And we always say in our training, and research supports that this rapid decline is not usually the Alzheimer's disease itself. If she even has it, it is all the other things that are have not been yet ruled out. So is there any, and now I know Lubbock quite well. I don't know if we know it, we've been there quite often. Is there a medical facility that there or in a close enough area you could go to that has a memory clinic that can actually do a thorough differential diagnosis and start answering some of the questions that we're raising? Is there one, I know, someplace in the vicinity? And Seth, do you know where we could find one?
Where's the U? I mean, is it part is in that area the part of the UT health system? Is that the major?
We're Texas Tech, so we've got Texas Tech Health Sciences Center is what
Well,
we have.
that would be it. Yeah, I mean, even if you go there, it's all a matter of do they know what they know? I mean, because they're all going to start with their own internal biases and opinions already. But I think any physician, I like to believe, even if someone with Down syndrome and IDE and maybe Alzheimer's, that they themselves know that there's workup, there's all testing that is done, and they should know that you should not be jumping to a conclusion, even though they think of it as a high risk of prevalence of getting Alzheimer's disease early as it may be. That they must know that you got to do a scan of the brain. They must know there's risk of seizures. They must know there are these Hashimoto comorbidity issues. They must know about, they have to know these things. It's all a matter of realizing it and then saying, let's do it. And then realizing to do it, we might need to do an under conscious sedation. And it's a matter of recognizing the family, if is the family members themselves, they're the ones, a guardian and power of attorney, are they not?
They are, yes. And
Right. So they're decision making. So they're the decision
right.
making. And you almost have to kind of be out there and ask these things. As we are in our hub here presenting to you, we're making suggestions. We have certain parts of the information, but not all the details. So we're, providing this information sincerely without being overly
Sure.
judgmental, I guess, and basically take it from where it's at. But I think that the challenge, though, if this continues to go in the direction it's going, you're not looking at a good outcome, as you know. This is a progressive condition. And when you're progressing in this direction, the risk of complications build up over time. And that's how people die. They stop swallowing, they get aspiration pneumonia, they get all the bladder infection, they get the sepsis from body shutting down, they do get the clots. And that's basically the end result on what happens, the terminal nature of these conditions. So if there's anything reversible in this one, now's the time to look at it. Otherwise, the horse has left the barn, sadly enough. I hate to put it in those terms, but that's kind of really where you're talking about.
And yeah,
I
and I
will
will
also
say,
guarantee, I'm sorry, go ahead.
oh, it's okay.
Go. No, go
Well,
ahead,
two
go.
things. I misspoke. Actually, they are working towards guardianship. She has been her own guardian. So I don't know if that was presenting an issue for them in the
Oh
hospital
my
with
goodness.
the
Okay, wow.
testing.
That could have been.
They're working on that. I believe they've got some medical power of attorney of some sort, but I
Right.
don't know if that was something that was keeping them
Well, it
from
says a
that.
lot about her level of independence she had before. The
Yes,
fact that
she
she was
really
so power of
did.
attorney, that says a lot
Yeah.
about how
Yeah.
she used to be.
Right.
Well,
And
and
that was my other
given,
piece, which was I will defend the in-between times to me, and I'm certainly, I'm a layperson, I'm not a medical physician, but does present to me as more typical dementia of some sort, with the kind of progressive loss of memory and that sort of thing. But it is these episodes that are very unusual. And so I personally don't judge the initial diagnosis. It's this presentation that we're faced with now that seems very unusual and
Is
seems
she
like,
followed by a neurologist? Is there a
yeah,
neurologist involved?
yes. Yeah. And he seems he's a well-respected neurologist in the area and is sort of the one that
Yeah.
people go to when they have Down syndrome. However, that doesn't mean that he's got a very large caseload of individuals that have Down
I
syndrome.
mean, I haven't quite done this, but if they want to reach out to me, they could contact me, even the
Wonderful.
neurologist, because I'm
Wonderful.
a national educator to neurologists, and this is kind of what I do through the American Academy of Neurology, and I'm internally involved in that. But if they wanted to reach out to me, talk to me, they can.
Fantastic.
we'll put that
I
in one
will,
of the recommendations.
Yeah.
I think, I think, you had said it, and that to me is my thing. She's at risk for developing Alzheimer's, and she's a little still on the youngish side, but certainly not unheard of. So could
I've seen
that
it.
be playing a role? Yeah. Could she still develop it in the future? Certainly. But I do think, and I really want to reinforce that, if there are any potentially treatable conditions that are making this worse, now's
Yeah.
the time to rule them out. And I'd throw in a third one, which I think is probably not really all that likely, but the symptoms could match up, and that's celiac disease, which people with Down syndrome, I know it's one of Dr. Chacoin's big things is undiagnosed celiac disease, and something he always looks at. And again, there's a blood test for that. So that would be another one. But I think, to me, that initial diagnosis from 2 years ago of Alzheimer's, if indeed it was based on, she had this sudden onset of, mobility or whatever that wound her up in the hospital. I wouldn't, if nothing more was done than diagnosing her with Alzheimer's on the basis of her age and the symptoms at that point in time, and she didn't have any more, thorough, because this is always a diagnosis of exclusion. I mean, you got to exclude any potentially other things, and it does, on the surface, it doesn't sound like that was probably done. So maybe it was, but a lot more things I think that could be ruled out, just to make sure that you haven't overlooked anything that potentially could restore this lady to a better level of functioning for her quality of life. So yeah, I saw Kathy had her hand up.
Yeah, just then I'll take my hand down. But one of the most important things I want to add is I'm sure the vestibular and proprioceptor systems have been severely damaged through all the things that have happened to her. She is lost in space and time, and now she's been moved to all brand new environments. I highly suggest that the parents take photos of her bedroom, kitchen, some of the bathrooms, some of the areas she lived in that may still be some routine and habit. Take photos of the areas now of her house, and if she goes to program area, and look for how you can replicate those things that are good from her previous, same bedspread or style, same colors, making sure that you're creating pathways, good lighting, really helping her be able to move through space and feel safe through space. I've had worked with a lady. It took us a year to get her to go back to walking, and all she would do. And she's a woman with Down syndrome. She would literally run from one place to the others because she was so lost in space. She had to get there because she was afraid she was going to fall in between. And it took us a year to get her to use transportation again and go back to a program. So there is rehabilitation here. There is the possibility of creating that environment and making her feel safe in time. Photograph the environment. And again, you can send those to me if you want to. Be happy to give advice of some ways you can change that to make it supportive as well. So always think of her as being lost in space and time and find ways to help her being
So
there.
just to let you know, I got to run. I got to see a patient.
Yeah, that's okay.
I'd love
All right,
to
guys.
have
Thank you
this
very
case come back again in, a couple of months, let you and the family maybe kind of tease out some of these things, see if you can get some of, these blood tests done and, maybe hopefully an MRI, and come back and let us know. We'll give you a written list of the recommendations. But then come back and let us know if anything turned up that we kind of teased out. Cameron, did you have?
I'll just echo from a brain science perspective. I agree with all of this, that the pathology and progression of Alzheimer's disease is typically the turtle, not the hare. And so the spikes in the episodes, as we've discussed, is perhaps a different etiology. And I think the hub team has given some excellent suggestions and support regardless of the diagnosis that we've also discussed, as Kathy mentioned, were the environmental pieces to help her feel oriented and more familiar for places that she's loved in the past. So I'm encouraged, and I hope that what is a help is the bulleted list that will provide you with suggestions to pursue. Of course, we know they won't all get done in a few months when we hope that you'll check back in with us, but that it at least gives a direction for the path forward.
Yeah, I'm very grateful. I know the family will be as well. They're a wonderful family, and I know they just feel very lost and confused. So this has been very helpful.
Well, and we'll make sure to, Dr. Keller offered, if they want to reach out to him, I'll make sure I get you that information afterwards on how to do that.
Great.
Well, thank you for coming and sharing. We'll wrap up to everyone that's joined us for this hour and a half and say thank you for spending time with us. Catherine, maybe we'll turn it over to you for the concluding remarks, telling us of future echo dates.
Yes, let me put that back up. I'm not going to try and make this in slideshow because for some reason on this slide, it always messes it up. So I'm just going to leave it there, but the next session is January 21st. If you would take a moment and scan the code there. Our funder is the Texas Council on Developmental Disabilities through UT Health, and we want to thank them for their support. And they have a little brief survey that they like to have people fill out. So if you would just take a moment to fill that out and provide them with some information, we would greatly appreciate it, as would they. And we will see you in January on the 21st. Hope everyone has a wonderful holiday and is safe and gets together with family and do all those wonderful holiday things wherever you are in the country. I'm sorry not to be seeing snow. I'm from Maine. We used to have wonderful white Christmases. I now live in South Carolina, and we don't want a white Christmas here because no one knows how to drive in it. So with
Send
that,
you a whole bucket full if you'd like.
yes, because Kathy Bishop is up there at the foot of the Adirondacks with plenty
4
of
feet
snow.
so
4
far
feet of
we have.
snow. But at any rate, wherever you are, we wish you and your families a very happy holiday season, and we look forward to having you with us again in January. So with that, thanks very much, and I'll be following up with our case presenter with the recommendations and contact information and so forth. Thanks, everybody.
Thank you.